A very good afternoon to all of you. It's a real joy to be here in UP. This is the decade of UP. For years, others were saying UP is not moving fast enough. Next 10 years, we will show them how fast we can run. This discussion is about acceleration. That's the only word I will use. I was telling somebody just now that if you see a glass which is half full with water, some people say कि काफी पानी है, थोड़ा सा बाकी है, and the others keep looking at that empty space and say ये क्यों नहीं भर रहा है, and that describes you. Confident people will not accept that empty space. Weak people will keep defending that that half glass is sufficiently full. Attitude. What we need in India today is a new attitude and energy. And I think that's the kind of energy that our new Prime Minister has given us. How do we translate that new attitude into performance? I speak about a subject which is called beginning from the end. I like to think about my week from Saturday, not from Monday. So I tell myself on a Monday morning, how do I want to feel on Saturday? What should I have accomplished? And then I reverse engineer. In a similar way, our goals are very simple. We have a certain set of problems to solve. Those problems are well known to you. We have an infant and under 5 mortality, which gives us enormous scope for reduction. I don't even want to argue whether NFHS 4 is right or some other scheme is right. The question is, there are more deaths happening in under 5 children in UP than should happen with today's knowledge. 2, we have an enormously high rate of stunting and wasting in children. Height at 2 years of age is the best horoscope in this world. It is the best predictor of adult income, adult education, risk of chronic disease, IQ. Demonstrated by Nobel Prize winning economists time and again. After 2 years, you can't catch up height. It is not about cosmetics. It is a reflection of the way you develop in fetal life and in the first 2 years of life. Unacceptable. 25% babies are still born low birth weight, maybe even higher. Why? Our environment, in the way we look after our girls, our mothers, our adolescents, is improving but not enough. We still have an acceptability high load of diarrhea and pneumonia deaths. Unacceptable. Remediable. जो मेरे हाथ में नहीं है उसका मैं कुछ नहीं कर सकता। अगर मुझे 20 न्यूरोसर्जन चाहिए तो मैं उनको कल नहीं बना सकता, लेकिन डायरिया और निमोनिया की डेथ को मैं ख़त्म कर सकता। उसके लिए मुझे न्यूरोसर्जन नहीं चाहिए, ये हमारे हाथ में। न्यूनेटल मोर्टेलिटी बहुत है, इम्यूनाइजेशन कवरेज 50 है, 60 है, फिर भी 40% बच्चों को एक सिंपल खूबसूरत टेक्नोलॉजी का फायदा नहीं मिलता। 20-20 साल लगते हैं हमारे देश में before new vaccines are introduced. Now the Prime Minister has changed that, but now it's our challenge to take it to children. So the problem is very clear in my mind. Some things I need to prepare for future, which is my health system. The Secretary talked about financial security in health, access to health, quality of health care, measurement, accountability frameworks, human skills, human capacity, institutional systems. These require steady day-to-day work. This is a grind. Some things I can finish in 2 years' time. The question is, do you have the right strategy to solve that problem? And that really is what we want to learn in this current discussion. What are those interesting strategies that can achieve acceleration? The IMR and infant mortality in the state is declining 1% per year. Can you make it simple? Undernutrition and stunting is declining about 1% per year. Can you make it 2? Can you make it 3? Acceleration in the current pace of, nobody is saying there is no improvement. It's not enough. I was recently in a meeting where we tracked all the deaths of children from 1980 till 2017. The slope looks like this. This is development. This is not healthcare. Because it happened in DRG Congo, it happened in the worst parts of this world, that the curve looks the same, the direction of the curve is the same. Now, that means who governed well? The ones who governed well is those who bend the curve. What could happen in 230, can you do it in 220? Can you do it in 222? Can you do it in 23? That is good governance. We take credit for what people do. I was myself a secretary for 10 years in the union government, and what I saw most is that we were happy to take credit for every damn thing, whether we did it or not. She's smiling because she understands what I'm saying. But I have seen people who bent the curve. Tamil Nadu bent the curve. They achieved 10 years ahead of time what others took time. So the point here is, this discussion is about bending that curve, achieving acceleration faster. And this requires an attitude. Somebody was telling me it's difficult to spend money in government. Rubbish. Smart administrators know how to spend money. Clean, non-corrupt people are not afraid of taking decisions. But the attitude is that you want to cite a problem why you can't accelerate. This becomes an attitude. There is no solution to this problem, if that is your attitude. So my single message today, reflect on how you think about these issues and about your attitude, and connect it with the promise of tomorrow's India, of tomorrow's UP. And this means a lot of self-punishment. I am a researcher. Every time I write a grant at this age, I write it 20 times again, because I am angry that I didn't ask a beautiful question. I can't tell you how painful it is to be a good researcher, because nobody is forcing me to write about it. I tear and my secretary gets fed up of me. She says, "Abhi to bahut sundar lag raha hai." I said, "Nahi, thoda aur sundar ho sakta hai, clear nahi." So it is about excellence. So I don't want to hear the word good in India. I only want to hear the word upstanding, in effort. Not rhetoric, performance. When I said beginning of the end, show me the faster decline in death rates and undernutrition, I will salute. So today's discussion is about how can we achieve acceleration. No defense, we're okay, we're fine. We're not terrible. We have a lovely country. We are beautiful people. But we are not living up to our potential. This is an honest communication with self. Why is it that only 30% of patients use public services in India? There must be something which is not sufficiently attractive about us. This is introspection. Because public, when it makes a choice between private and public sector, is quite honest in making a judgment ki jaun ke nahi. Mr. Manmohan Singh, when he was the Prime Minister, he told us a story at a dinner at his house. He said he was crossing in the lawn and his maid was coming from the other side. So she said, "Sir, मैं 1 minute आपसे बात करूं?" तो मैंने पूछा, "बोलो." She said, उसने जेब में से पैसे के नोटों का बंडल निकाला और कहने लगी, मेरे बच्चे को प्राइवेट पब्लिक स्कूल से एक इंग्लिश स्कूल में दाखिला। He said, मैं इतना शर्मिंदा हुआ, मैं उन दोनों मिनिस्टर थे, he was the finance minister those days, कि मेरे घर में मेरी मेड को मेरे स्कूल पे विश्वास नहीं। This is client satisfaction. This is quality. How do we become attractive in public services? How do we become attractive in governance? How do we stop admiring problems? How do we become solution designers? How do we visualize a new health system which is capable of absorbing the new complexity of chronic diseases, so many other issues? This requires some imagination, it requires some translational power, it requires experience. You can't get experience without trying things. Some risk taking. We want million champions in the health sector here who will try new things. And our secretaries would tell us, you did such a good job, if you failed, it's okay, try something else. Experiment, empower. I was actually yesterday writing a final chapter on the review of the Indian Council of Medical Research, which the government wants everything to be reviewed, and I put only one line there. I said that I wish they empowered more and enforced accountability less, because I am tired of being asked questions by everyone in this country. So can we empower this whole machinery to perform at a higher level of quality? Can we inspire each other? This is what we are talking about. But we are practical people. Inspiration is not enough. Inspiration has to have some practical strategies and actions in it. So this discussion is focused on transforming UP's health performance. Not because we are sick, but because we are capable of being even better. It's a transformation issue. It is not an incremental change issue. How do we move from incrementalism to transformation? How do you develop that courage to disrupt new solutions? Very simple issue. If I don't have doctors, I don't need a doctor to treat diarrhea at the moment. Do you have a strategy? I don't think we need them. In many places there may be a problem than a solution. So we have to create strategies which will work in our circumstances. I like what Mr. Rao said. Let us identify the doable. Some things we can't do. We can't produce psychiatrists in 2 years' time. We need to start planning how to do it. But it's going to take time. But there are many things you can do tomorrow. We have an ICDS program, but we have 1% decline in undernutrition. For God's sake, we should be asking a question, is this the best way to do it? The end is very simple. It is the rate at which it is declining. Why are we defending a mechanism if what we want to reduce is not being reduced? So it's an issue about an honest dialogue about effective strategies. And there are challenges which you and I can't handle in a 10-year perspective. So be it. There is nothing we can do about it. So I'm going to, with these few comments, request my panelists to as you define where we want to be in 5 years' time, give us 4 or 5 sharp strategies that will work in the context of you. The public, the policies are all visionary and they're good, but they don't give you the strategy to implement. And implementation without strategy is lousy. When the challenge is complex, every civil service friend I talk to say, यार implementation की problem है. मैं कहता हूँ नहीं, strategy की problem है, design की problem है. सुबह शाम पीटने से लोगों को कुछ नहीं होगा. अगर एक सिस्टम डिजाइन गलत है, उसको थोड़ा रीडिजाइन करो. करंट ICDS के डिजाइन से न्यूट्रिशन हिंदुस्तान में कम नहीं हो सकता. इसको समझने के लिए किसी को जीनियस होने की जरूरत नहीं, क्योंकि उनका 2 साल से कम बच्चों के साथ कॉन्टैक्ट है. तो इस पर क्या कर सकते हो? तो रीडिजाइन करना चाहिए. तो अब अगर मैं उनको बोलूं आप इम्प्लीमेंट बेटर करो, a design failure, a flaw cannot be corrected by hard work. It needs a little bit of redesign. So we also have to use our imagination. So in some cases, those type of ideas are what we need. Thank you very much.
Hi, good afternoon. My name is Sunil, Mehra. I'm a pediatrician by background. So difficult to talk after Dr. Bhan has spoken, right? I've been listening to him for the last 30 years or so as a student and as a professional. One thing I have always learned from him, the moment he speaks, you start getting motivated to do something more than what you're already doing. And he has been doing it to all of us for ages. I hope he does this to this audience too, and the audience goes back with those messages more strongly. But to begin with, my connection with UP is for 30 years. I've been coming to this state and working in this state for many years. Many of you in this room I've worked with for so many years. But for last 9 months or 6 months, what I'm seeing is a different energy. And this is what makes me really feel excited. Is this energy going to carry on? Is this energy going to get converted into some doable actions which will convert or change what we want to change? Having said that, I think change won't happen automatically. Change has to happen, as Dr. Bhan said, with certain new strategies and certain new thoughts which can be brought within the system, which evolves the capacity of the system, while not just evolving the capacity, at the same time bringing a kind of thought process which has some innovation involved in it and not just goes the way it was going on. Then what do you do? What do you stretch? What do you take it forward? What I thought about this session was exciting it was talking about youth bulge, the subject I love a lot, and the dividend that UP achieves out of investing in its youth. I think for years there has been a lot of emphasis on 2 spurts of growth, fetal and first 2 years. Somewhere we forgot that there was a 3rd spurt, and that 3rd spurt investment was extremely poor for last 70 years. Last 10 years or 15 years has seen us understanding that this 3rd spurt has something to contribute to ultimate health outcomes or the deliverables that we want to work at. And at my institution, or at my personal interest being a pediatrician, came this 10 to 19 and 10 to 24 investments. Why should we invest in this age group? I think many of the things that Dr. Bhan spoke about, the newborn, about the under 2, has to do with what goes into that in this age group and when they deliver the babies and the subsequent ones. All about the mental aspects, the developmental aspects that come with this age group, besides all the reproductive health and sexual reproductive health changes, nutrition needs and other aspects, are something very critical for what we achieve in our newborn or in the continuum of care that we want to achieve through RMNCHA. I see this as a low-hanging fruit. Why I say that this is a low-hanging fruit? Because even slight investment in adolescent, there is good evidence to say, engage with adolescent is enough to change certain set of practices and behavior. Engagement alone can deliver on that. I remember developing my first adolescent development center way back in '93. I'm not a researcher, I'm an interventionist. And I love to say that I want to intervene, I want to reach people, understand, and then support the systems and policies to reflect the needs of those people. And what I thought was that the moment the adolescent girls came out of their home into these spaces, there was a transformation in terms of their behaviors and thought processes, in terms of saying they started asking about going back to school, going back to the livelihoods opportunities. And this was not planned. It just bringing them together brought this aspect of these girls taking the agenda forward. The recent Lancer Commission on Adolescent Health came with 2 mother interventions. And since you asked for the suggestions, I think, the 2 mother interventions, it said, that could transform a lot of economic and maternal and newborn health outcomes was to delay child marriage and keep girls in school. Child marriage was seen as one of the mother of interventions. And UP State, if I go district-wise, has in the range going from 20 to 40%, not just girls, boys too. And with the moment that happens, those social determinants and their influence on the health of adolescent and subsequent health on the pregnancy and the newborn outcomes are significant. And hence, let's start imagining that if today, if I had a workforce, that's a big challenge. I had a workforce or I had a mechanism to reach, because we know the data that almost 1/3 of India is between 15 to 24, 10 to 24, and UP is no different. If you are 22 crores, you are about 7.5 to 8 crores is about 10 to 24. And many of them are getting married, producing babies very quickly, and going on to produce more and more. Your TFR is much higher than many other states is. What do? Do we push contraception or do we delay age at marriage? I think these are some of the tough additions that can be taken to influence the RMNCHA outcome. While doing that, you also look at the nutritional aspects of it. If you look at the nutrition aspect, of a girl who's not married versus who's married, we have good evidence to say you go into marriage and your nutritional status declines. And hence your reproduction part starts showing its effect. So can we keep them out of that? Third, I think which is very, very critical, that some of the young people's dividends that we want to achieve is not possible if we do not have a young person who is not smart, quote unquote. By smart, what one means is that he has good health, he has education, and he has a livelihood opportunities. I was sharing in the morning that there is a good evidence now to say smart young adolescents or young adults are by themselves is a better contraception than any contraception that can be used, because they automatically choose to have less babies. They automatically choose not to have repeated pregnancies. So in the end of the day, investing in young people as they exist and getting the dividend out of it is basically about 3 or 4 aspects of investments. One, retain them in school as long as you can. So often I feel health cannot be achieved through health wallahs. A lot of other sectors, intersectoral inputs have to go to achieve the health that we want to achieve of our populations. 2, keep them outside marriages as long as you can, preferably 18 to 21, you will get the healthcare dividends. And link your educational system or out-of-school system to livelihood opportunities. Do the intersectoral convergence. Easy said, I know that. Difficult to do, but if you could do this in one sector of investment in young people, my feeling is, and I'm pretty confident, that in the end of the day, you will get the faster, quicker results that I think Dr. Bhan was asking us. And there's evidence now which was not there about 15 years back. We have that evidence now to say that when you do these investments, And the workforce is very varied for that. Now the new RKSK program that the Government of India has launched, being part of from its inception, I strongly believe if put in its right spirit and put in the right mechanism that it has been envisaged, states are going to see not the outcomes just on adolescent health outcomes, they are going to see a significant impact of it on their IMRs and their MMRs. This is a long-term investment, not an immediate for your IMR, MMR, but you're going to see a significant impact. I really feel, talking about young people and the bulge that we have in Uttar Pradesh, and with the Prime Minister, Honorable Prime Minister, focusing on them a lot, and the state now really trying to invest a lot in this group, for all the right reasons, it's an opportunity for us. It's a great opportunity to us that even if we have 4% of our total pregnancies which are adolescent pregnancies, we need to get that out. Get that out of the system. It's likely to show impact on your MMR and IMR directly. One issue which we tend to forget while we do all this is investment in boys and men. And I'm very intrigued when I keep on hearing, I was talking to one of the NHM functionaries here in UP in the morning today. He told me emphatically, sir, MCH to hum आशा ANM से कर लेंगे, पर non-communicable disease और infectious disease हम आशा से ANM से नहीं कर पाएंगे. हमको उसके लिए कोई new worker चाहिए. और उसके लिए क्या मेरे को male worker मिल सकता है? Can I think of a male worker, or can I think of a second ANM, or whatever you call it, as male health worker along with the ANM to reach, according to me, we have enough evidence for that also. Investing in boys and men improves the reproductive and maternal health outcomes. We know the answer, but we want to put it under the carpet. We don't want to hit it. I think we need to hit it sooner than later. Get investment in boys and men. If out of $10, invest 7 in women, but do invest 3 to 4 in men or boys, you're going to get much better health outcomes as the deliverables than what we had been all the, not to say not to invest in women and girls, please don't go out of this, that I'm trying to push that. I'm saying we need that investment in men and boys. Alternative mechanisms need to be put in place where we reach our men and boys for the health outcomes that we want to achieve, especially when we are talking about the burden of non-communicable diseases, and especially when we are talking the burden of the tuberculosis and beyond. Lastly, and I think that's very critical to me, is the health workforce availability for addressing what I'm talking about, right? Do we look at an alternative health workforce? Do we need to look at workforce beyond health sector which can contribute to it? Do we see the role of media very strongly in influencing health outcomes? Do we see the role of school teachers very strongly in believing in terms of the health outcomes that we want to teach, that we want to bring? Do we want to see the workforce of such huge workforce of panchayat, which we have been always talking about, have never been able to bring and mainstream them, although we have been talking about it. But somewhere we have to look at alternative mechanism of workforce beyond. Although the peer educator approach in RKSK is being talked about, it has shown mixed results, but we have no choice. If we have to reach young people, the present workforce is not, I would not even say that they are not competent, but they don't have the enough space and time to deliver for this workforce. So peer educator was brought in for RKSK, even if it's a bad choice according to me, but it's a choice worthy of taking so that you can reach the unreached populations through a mechanism which is locally generated, but if executed and mentored well, there is good evidence that it can work to reach that subset of populations. So I think we need to take it fast. My strong recommendation to state would be to move RKSK faster than you are even thinking of. You will get much better dividends, and you will get and state and center is supporting you in all possible ways. I keep on hearing from center, state is not moving. So I think it's about state moving and taking those resources adequately and taking it on. Thank you. Thank you very much.
Thank you, sir. Well, Dr. Bhan said I should introduce myself. I'm Vinod Paul. I'm chair of the Department of Pediatrics at the All India Institute of Medical Sciences and have been associated with Child Health Policy and Program for long. Had opportunity in the past to work in UP as well. So it's a real privilege for me to be here. Now, I would make three broad comments on three broad areas. Firstly, to set the stage. Secondly, Dr. Bhan has just now charged us, unprepared as we are, to set the goal for the next 5 years. And then to elaborate on what could be done, what should be done as a priority. So let me begin by setting the stage. And it is a glass half full or half empty, as you may like to see, but I think we need to take stock of that. First and foremost, I would begin by saying that our state of Uttar Pradesh has not done badly given the challenges in the MDGs. Why am I saying so? In the country, we started with an under 5 mortality rate of 125 and we ended up at 43 in 2015, just missed the MDG 5 by 1 point or 2 points, you can say. That's a 2/3 reduction, by the way, 66% reduction. And it's notional to say that India did not achieve MDG 4. So that's India's story. UP, we began with 152, sir, in 1990. And in 2015, SRS, this is all SRS, I'm not confused about one or the other, SRS, both, 51. So first let me use the word congratulate. We should accept the fact that we have made progress. We have, if there was a state-specific MDG 4, we achieved it. And maybe several of you may not really know that the quantum of change that we have achieved in under 5 mortality is equivalent to achieving MDG 4. And that's contribution of all of you, of the politicians, of the bureaucracy and the society at large. So I want to put that on record, sir. And in this regard, we are all in the company of Gujarat, J&K, Karnataka, Maharashtra, Tamil Nadu, West Bengal, Delhi, who are the other states who achieved the MDG 4 of their own state. And that's important. We may also note, in terms of setting the stage, that in the last 10 years, there are important improvements which we must take note of. For example, the proportion of women married under 18 years has dropped from 59% to 21%. That's a huge change. 59%, 21%. That must have an impact on development as such and, of course, health indicators. Let me pick up one or two more. 4 ANCs, 11% has jumped to 26%, not bad. Immunization jumped from 23% full coverage to 51%. Of course, 51% is half empty, accepted, and I'll keep saying that. ORS usage has jumped from 12% to 38%. 38% is low. Bangladesh has 72%. So there's a long way to go, but we have made some progress. Cesarean rates from 4% to 9%. Cesarean rates are still low, and that explains relatively poor progress in MMR, at least partly. One more data set. This one. Okay, we leave it there. Now, on the maternal mortality, between 1990 and 2015, we have reduced MMR by 50%. We are far away from achieving our own MDG 5, which means 3/4 reduction, 75. But that has been the tough part. We are at 285, which is abysmally bad. There's no question about it. It's very high, higher than most of the countries in Africa and so on. But that will come to how we have it. So one point that I've tried to make is that yes, there has been progress in spite of low budgets, severe social changes that have happened and constraints that have been there in our state. What definitely worries us in many ways is the following. For example, that severe wasting, sir, is 6%, which actually has increased in our way. Cannot be acceptable. Severe wasting means hunger, disease, and these are the poorest people. And you talked about 1% decline in wasting, which is just a natural phenomenon. Very concerned with the fact that 2/3 of our children are anemic, half of women are anemic, and a quarter of adults are anemic. We have done very poorly on that. So that's the part which is the future agenda. Having set the stage to an extent, let me just point out what I think, or record what I think could be the provisional goals in the next 5 years. Come 2022, which is the outer limit of the life of this government, and that happens to be the 75th year of independence, which is a good thing to remember. May I propose, sir, that we move in the following way. Our current IMR is 46. We aim to bring it down by 50% to 25, 23. Less than 25, shall we say. I think it's doable. Because the things that are required to make this difference are already known. They are already happening here, and they are happening much better in several other states. We know how to do it. It's a matter of giving the managerial, financial, and health system and community mobilization engines to that pursuit. So it can be done. Let's say we would reduce it by 50% in the next 5 years. That would correspond to something like 31 NMR becoming about 20. So a provisional goal, that's biological or epidemiological. That's how it behaves. So if you are at IMR of 23, the NMR would be around 19 or 20, 19 or 18, and you could say less than 20. So that's the goal. For MMR, we do the same thing. We reduce it by 50%. Because development is taking place, roads are being built, we are trying to do the right things, and we would come to the point what more can be done. I think it's possible. With that 150 in 5 years, you will be in the company of most of the states, the average level that we are now presently looking at. I have another goal, sir, and that is reduce severe acute malnutrition by 50%, from 6% to 3%, doable. We have protocols, we have potentially the SOPs, the monitoring systems, and we can do it. So I'm putting these 3 or 4 as the goals for the next 5 years, and Dr. Shally, you would kindly elaborate on the postnatal part and the nutrition part of how to achieve. But I'm challenging ourselves that we can achieve this, we can surely achieve this. Not to forget the fact that the central government has would enhance public spending on health by 1% or 1.2%, which is almost double. State would get part of that, huge part of that. Also remember that there are other things happening by way of the national health policy, which will expedite, and I'll touch upon them when I say specific things to be done. So this is about the goals. Now, in the next 5-year horizon, we would largely be doing the unfinished agenda. And the unfinished agenda in the context of maternal and newborn health and postnatal health of children, Dr. Shally Awasthi will kindly do for us, because she's done so much of great work in that area, is about doing those things which other states and other countries have done well already. For each one of those things, except 1 or 2, which could be the new additions, all the protocols are available. Tamil Nadu has a maternal mortality rate of 80. I mean, what have they done? It's ambulances, emergency obstetric care, emergency obstetric and newborn care. We have those protocols. We haven't done enough. We have not done enough by way of spread in terms of coverage. We haven't done it well in terms of quality. So there is nothing new to be brought out to be able to achieve the goals that we have set, and even as we prepare for the SDG agenda. Now, for maternal mortality reduction, the standard model is, just to enumerate, is about birth spacing, care of the girl, child, adolescents. That's one part. But the second part is high coverage of quality antenatal care, including correction of anemia, skilled attendants, emergency obstetric care, great ambulances. That's all. No delays. 0 to 3 delays. Okay? Now, the new element into that game would be the fact, or the twist that we need in this state is that here we are dependent on the private sector. We do not have enough of EMOC sites for the critically sick woman who would require a blood transfusion or a cesarean section in the government sector, which is true for many other states, but I think here the situation is very. So one important aspect would be, can you innovatively connect this bit of care to the private sector through a financing mechanism? So if you bridge that, because there are private sector institutions, you have ambulances, make them more efficient, but if you could connect and give in a certain way a bridging mechanism for poor people to get connected to the private sector, this would get accelerated. Even as we develop our own public health system with obstetrician, not going to be easy. Because the current state to me seems to be so weak. So if you want 5-year horizon, poor people have to be connected to the private sector, and the new national health policy gives you that room to do so, and you should be willing to spend money on the lives of women. Coming to newborn, one part is maternal health, all that I have previously stated, including birth spacing. The second part is skilled attendance. The third part is postnatal care of the babies in home settings, which is about home-based newborn care, for which I hope you are training our ASHA workers. Then it is special newborn care units. I understand the allocation is 1 per district, which means 70, but maybe only half of them are functioning well. The rest must be suboptimal. So one immediate goal for us, or aim for us, is that in the next 2 years, or next 1 year, why 2 years, optimize the performance of all subsets, or all the special newborn care units, all 70 of them, all 60 of them, and then look at additional SNCUs to be created in the public health system. But even when you do that, because today's sick babies will go to the private sector, again you need a similar connection to be made. Can we enable babies of poor families to reach the private sector which is out there by way of financial mechanism? And again, potentially it is possible. The new RSVY scheme that Mr. Rao was referring to has this component of care of newborn babies with a package of up to 100,000 or 90,000 rupees to be sought from the private sector. So if you either get that RSVY plus version to be rolled out fast, as everybody is hoping, or create your own RSVY of sort to be able to connect small babies to care in private sector nurseries, it would help. A new dimension which the new national health policy has brought is the setting up of health and wellness centers. These are the far better and improved versions of sub-centers where ambulatory care would be the norm for babies, to women, to old people. These could be the sites of ambulatory treatment and ambulatory counseling services for newborn babies and children. And that's an opportunity which is out there. You will be rolling out these health and wellness centers because the government has tasked us to do so. There are resources, and we can strongly build, at least as we roll this out to the first phase and the second and the third, a strong component of good counseling and the postnatal follow-up of babies, particularly the low birth weight babies, and treatment of sick newborn babies on ambulatory basis. Because ambulatory care of newborn babies for non-life-threatening conditions is doable in this way. So in nutshell, what I proposed is that the intervention packages are the old familiar packages. They're already being operationalized here. We have opportunities of financial protection addition to accelerate the uptake of or improving access of services, reducing equity, and to use the health and wellness centers for part of the care for babies, children, as well as the mothers. But that's one way to do it. The next bit, just to wrap up, is to focus very, very intensely on detecting and treating babies with severe acute malnutrition, and to make sure that these babies survive There are activities related to nutrition rehabilitation centers, which should be taken to efficient level. New paradigm of follow-up treatment of these children at home is now available as an intervention, and that intervention should be imposed. In summary, sir, I have set the stage by saying that we have made progress, but lot part of the class is empty. We can accelerate, we can bend the curve, provided we are committed to it in a full sense. Because we're dealing with intervention packages that are familiar, that have been done well in parts of UP, and of course in several states, and we can take them to scale, ensuring that no one is left behind. Thank you very much.
Thank you, Professor Bhan. And let me introduce myself. I am Shally Awasthi, Professor of Pediatrics in King George Medical University. And I have the privilege or the advantage of working in Lucknow, also working in community for last so many years. And I've seen the best and the worst. I've seen the underbelly, as well as examples of what an empowered community can do in Uttar Pradesh. So I would go into facts and figures which everyone has said, what percentage mortality, what sustainable development goals, etc. But what I would like to tell you is that in children beyond neonatal period or in young infants also, still the common causes of death are pneumonia untackled, diarrheal diseases partially tackled, and severe acute malnutrition yet there, confounding the problem. Now what I've seen over the last so many years is that to tackle with any of the problems, the community has to move out and seek care. But before moving out and seeking care, there has to be recognition of illness. The illness itself is not recognized. You would think that I've been working in pneumonia. Pneumonia is definitely not recognized. They aren't aware about it. They weren't recognizing it. And when we made them aware and recognize illness, there was improved care seeking, increased demand for services. So what I'm trying to say is that besides ensuring that there are Indian public health standards, we have to work very strongly on the community side. We have to work on awareness creation for illnesses, recognition of illnesses, and then care seeking. And I actually like to call it the health arc: awareness, recognition, and care seeking. And until that health arc is not well done, no amount of strengthening the government services or the public health service will work at all. Same is in diarrhea, but it is confounded further by the fact that the community knows the use of ORS. They do use the ORS, but when there is severe dehydration requiring intravenous fluid, then who gives it? Can we rely on the pediatrician? Can I have the health secretary, Mr. Rao, or Madam say that there's no orthopedician, there's no cardiologist, there's no neurologist? We cannot say, because we cannot have a pediatrician sitting everywhere. Therefore, an MBBS doctor who has cleared pediatrics as a major subject should actually re-invoke his knowledge of pediatrics and start putting in the intravenous line and start managing the patients. So how do we go about doing that? We go about doing that by having what is lacking, and which Mr. Rao said, that capacity, not only capacity building, skills enhancement. As a health system, we are not incentivizing skill enhancements. There are random courses here and there, which are given half-heartedly, which are not linked to incentive, which are not linked to anything else, and therefore not done well, not taken well. We have to seriously focus on skills enhancement in all ways. Secondly, why only skills enhancement in patient care? We heard Mantri ji say, बोलते ठीक से नहीं, देवता है, पर कैसे बोलते हैं? What about soft skills? skills enhancement, leadership training, management training. Why can we not have this for our in-service candidates in ways which can be, motivational? You hear Dr. Bhan, the half empty, half full glass, you go motivated. Why can't some person speak, give structure to leadership, give structure to management, and you see what transformation can take place with the existing workforce we have. Now, I have been interacting with these people, right from Ashas to the doctors, and you all know the challenges. They will tell you the challenges. If I tell you, you know them. They say, Madam, कोई ऐसा नहीं करता. आप हमसे क्यों कह रहे हो करने को? बच्चा मर जाएगा, गांव वाले मारेंगे हमें. हम बच्चे को आपके पास भेज देंगे. आपके means KGMC में भेज देंगे. आप करो treat. Now the point is, there has to be an attitudinal change. बच्चा मरेगा, गांव वाले also see the efforts you put into it. It's not only the death, but the effort which counts and how you project your efforts and how you communicate. So, a lot of people were not taught communication skills in their undergrad. Let them learn now. Let them learn sometime in their life for there to be a paradigm shift. Now, you heard Dr. Paul say and Dr. Bhan said, what are the goals? Well, I would say 75% reduction in pneumonia deaths, because now we are also going to roll out the pneumococcal vaccine. 75% deaths in viral deaths, but you can't have it without intravenous access and fluids being given at the peripheral hospitals. You can't send them all to tertiary care. And to Sam, he said a modest 50% reduction. And I would really like to delve on nutrition story. Nutrition is beyond iron and folic acid, which hasn't worked for last so many years. So what we have learned about nutrition and undernutrition, and SAM in particular, is that SAM is not considered an illness by the mother. We worked on SAM and the mother says, chota hai, kamzor hai, ladki kamzor hai, choti hai, she can be a good marriageable person. Badi ladki achhi nahi hoti hai. So the issue is, when SAM is not recognized as an illness, how will they treat it? You can't have people looking into each and every child to identify SAM. So what I'm saying is that there has to be, what I would say, sustainable, in a very sustainable way, community empowerment, and that sustainability will come through an innovative approach. We should think about intersectoral coordination and putting together health and nutrition training, class 10 to 12, essential for girls and boys. And believe me, in the 5-year time frame which Dr. Bhan says, we would have a diffusion effect, a knowledge exchange in the community, and we would not then say one Asha is not enough, because we are empowering the entire community. How long does the Asha module take? If you take for pediatrics, the Asha module 4 and 5, 7 days. We can repackage it. I don't mean there are educationists who can be empowered to have it and give it as one class, once a week for class 10 to 12. Not only that, we can have innovations in that we can have evening classes for women, illiterate women also, and not only depend on PHND. So this is a time where Uttar Pradesh should think out of the box, should think that problems are not simply numbers, 50% dying, 60% this, 70% that. It is deep rooted within the cultural system, not only of the culture of society, in the culture of health services. And the culture of society has to change, and the culture of health services has to change, and the way administration sees the health services and empowers the doctors to function in a positive way, that has to change. So if I would like to wrap up and say a few corrective things, think positive, think of things that can be done in a different way, and treat medical services and medical personnel as a very highly intelligent class of people who require motivation, incentive, and the transformation can happen within 5 years in Uttar Pradesh. Thank you.
the last presentation by Dr. Jani, the State Immunization Officer of Government of Gujarat.
Respected Bhan sir, dignitary on the dais, dignitary of the dais. I will introduce myself. My name Dr. Jani. I have passed my MBBS from BJ Medical College, Ahmedabad. Also, I am MD physician and I have passed my MD from BJ Medical, Ahmedabad. Also, I am DPH and passed from C. Chitra Medical Institute, Trivandrum, Kerala. I have joined my career in primary health center in 1993 as a medical officer. I have worked for 7 years in primary health center, 4 years in community health center, and then I promoted as a chief district health officer in 2003, one of the best district, Mehra, from where the Prime Minister belongs, and also I promoted as state officer from 2010-11. Basically, I am state immunization officer but also holding the charge of Deputy Director Child Health. This is the real interesting subject what kept today, public health challenges and solutions. Really public health is a challenges. I have passed my 24 years in public health from primary health center. Very difficult and very challenging. You can't do dramatic change alone. It requires so many disciplines. Teamwork, coordination, public-private partnership, political will, commitment of the staff, all commitment of the staff. Already so many issues highlighted by our previous speaker, but the topic, how we can improve the maternal and the child health, again that is the priority of area of the all government, state government and the central government. And you know the last some years SDG and Niti Aayog. And Niti Aayog, there is a health index, and in health index, out of 1400 total marks, nearly 800 marks goes to maternal health and child health. Really good. Any country and any state has to take the priority for the MCH care. I will not address much, but what we have to do, everything is possible and nothing is impossible. Just identify the area. That is the most important. In 2005, 6, 7, Government of India changed the name of the maternal and child RMNCH plus A, and they have identified the high priority district. Very good initiative. But sometimes the district which is not high priority district, non-SPD, but some taluka of that non-SPD may be the serious one or the challenging. So my request, don't focus on the some district, even go down taluka level, even go down some PSC level. In a means I have worked in the best district, Mehsana, 48 PSC, primary health center, but for what so worse, even the high priority district. So my humble request, if we want to improve, then identify the specific area where we have to focus. So again in Gujarat, we have identified taluka, 77 high priority taluka, where the literacy rate is low, again female literacy is low, tribal population, SC/ST population, poverty, not only health index, but identify again on the scorecard, and we have focused in the 77 taluka. So my first request. Second, in the public health, what we require is basically the frontline worker, and that is the ANM or female health worker, whatever we call. And the second, already highlight, it is MPHW, multi-purpose health worker, basic worker. Without them, it is not possible to improve the services, MCH or non-communicable diseases. So again, UP has to take this matter, go according to the Government of India norm, population norm. Sometimes there is ANM, but she is capturing 12,000 population, 15,000 population. As per the norms, 3,000 population ANM required in the hard area, hilly area, tribal area, and in a normal area 5,000. Because I see, what happen if go beyond population, then the primary job of the ANM or the multi-purpose health worker is to go house to house visit daily, and they have to cover 30, 40, 50 houses per day. If we give more than 10,000, 15,000 population, then some left out will 100% remain. So second, my opinion or my suggestion, public health without frontline worker is not possible to improve. So second. Or third, capacity building, training. Because so sometime ANM, what she learned there, what MPRW learned there, and how to run the program according to the GOI guideline or the state guideline, that is different. They have only technical skill. Here so many area of concern, even the data management, so many format, multiple formats. So third one is capacity building. Fourth, at present we have very good NHM link worker, that is ASHA. We have to give the priority work there. In some area immunization is low, some area HbA1c is not good, some area maternal mortality high, and there is an incentive also in the NHM. So link the community with the health worker with the help or the utilization of the ASHA. Very good resource person, 1,000 ASHA per rural area, and in the urban area, slum, we have also the link worker, that is ASHA. So that is again my request. Fifth agenda, that is data management. Whatever NFHS say or whatever data, there is huge discrepancy. We are just giving the number 90%, 80%, 70%, but it is only number. But nowadays, there is a well-developed IT sector. So we have to utilize, and that is MCTS, Mother and Child Tracking System. And particularly in Gujarat, we are utilizing best Mother and Child Tracking System. Every record is available. Any mother, what is the name, what is the resident, what is the mobile number, high risk or not high risk, first ANC given, second ANC given, third ANC given, fourth ANC given. So best tool to improve is the MCTS tool. Don't remain on the number, absolute number. It doesn't give much sense, because some require services and that is not tracked by today, C or beneficiary remain without service. So that is my concern, right? Use the mother and child tracking system, where the left out, where the drop out, which service remain, and that is very good name based, right? Some 2-3 more suggestions to improve the public health, that is the private sector. I do not know what is in UP, but in Gujarat, private sector is more strong compared to government. Multi-speciality hospitals, so many. Town are well developed, corporation are well developed, and nearly 60% people goes to the private sector. If we want to improve the public health, then we have to go for PPP model. We require gynecologists. There is no need, means fill up post of the gynecologists in government sector. Pediatrician, anesthetic. So special care required where we have real challenge. So my humble request, we have 3-4 good public-private scheme in Gujarat. That is Chiranjeevi Yojana, that is Bal Sakha Yojana, that is Bal Sakha Yojana 3 also. Nowadays, Pradhan Mantri Surakshit Matrutva Abhiyan. So without involving the IMA or AOP, it is not possible to improve maternal and child health. Even some good initiative or the good coordination required between the public health and the medical services and medical education. Sometimes we identify the high-risk mother, we refer to the CSC or the district hospital, and they will not take care. So there is a strong linkage between the medical services, medical education and public health. Otherwise, what we put efforts in the field sector, the outcome what we want to achieve, it is not possible. Because 50% require community care and 50% always require facility care. Either in case of maternal death, you see number of maternal death in the facility. You see the number of death in the facility, means right, newborn death. So 50% work always goes in the hand of medical services, means district hospital, sub-district hospital and medical education. Sometimes they are giving good training or good capacity building, but they have to also see the mother and child care. That is most important. Again, we have to involve all partners. Either UNDP, either UNICEF, either WHO, because they play a very, very crucial role. Technical, what we can do, they can do even some printing material, IC material, micro planning.
Jani sir.
Finish. Okay. Only 2 points. So that is must. Micro planning, that is, I repeat again, all population of the state should be covered by the fixed day services, that is micro planning. And last, I say that we have to involve RKS. Sometimes RKS are functioning on paper. So my humble request, community involvement is must to improve the public health. Political will is must to improve the public health. Thank you for listening. Thank you.
Thank you. I thank all the panelists for very precise and extremely intelligent and experience-based points. So, for a couple of minutes, key questions or comments from the audience. Yeah.
Sir, I am Dr. Rinku Srivastava from SIPSA, and I am hearing the comments and suggestions of all of you. And I agree with Shally ma'am that yes, there is a need for that art, health art. And what is happening while I am working in UP for last 20 years, yes, we are focusing more on the quality as well as the access. But the link which is missing is the health-seeking behavior from the community itself. Our main focus for that is ASHA, and or we are depending on the Anganwadi. Although we all know the integration and intersectorial convergence, but how the public, they should come themselves forward for seeking the health behavior. One of the components during my initial work, we are having the NGOs. but we know that NGOs can work only in the pockets. Then how can we develop that? We require a solid strategy, like how the Panchayati Raj itself, they should develop the sense of that empowerment within the community. So any suggestion, because we are looking forward.
Anyone has thoughts about?
And we have very limited strategies to see the involvement of people for whom these strategies are. So as NGOs, why we succeed at times, I feel, is because we basically begin with the principle of that without participation there is no engagement, and without engagement there is no change in health-seeking behaviors. This mechanism to be set in is, age-old. I don't know if the people in public health would talk about 25 years back, or 30 years back, where there was a whole process about community processes and community engagement as fundamental to health. But this seems to have gone and taken over by health products and health services more than the engagement processes. So I think we need to go back to what we were doing 30 years. And I remember once Dr. Bhan, you asked me why ORS 20 years back or 15 years back is not. Because I think community engagement in ORS was minimal, and medical emphasis was so much on medical providers that they prescribed rather than me demanding ORS. So I think somewhere a disconnect between focus on medical services and less focus on the community. Because both that is seen as non-medical, I'm going to use the word non-sexy. That's not in the public health sector very much used. So I would go back to that principle of saying engagement is fundamental to health-seeking behaviors. People's participation is critical to changing behaviors. Get back to that mechanism. BHC actually was meant to do that, mind you. Village Health and Sanitation Committees were actually to do that. But we never empowered our BHCs to a level that they could bring that kind of participation and health engagement. So
I think this is, what the point is, we recognize this age is bad, but we haven't vitalized the instruments that we created, and we should get back to it. You have a point here? Somebody want to bring it? Yes. Can somebody please circulate a mic quickly?
Mic is with me and I want to ask a question.
Okay, so I would love to hear a lot of solutions. Okay.
My question is to Dr. Paul's observation about expressing satisfaction about UP's achievements in maternal health and other even child health also. While not contesting your observation, I would like to say that the problem must be seen as that deaths that are taking place are preventable deaths, and that is the saddest part. And even reduction from 420 to 285. 285 deaths are also quite a big number comparable to even sub-Saharan African countries. So feeling complacent at this stage, I think may not.
Absolutely agree. Maternal mortality issue is a concern, and we have to address that. No question at all.
Yeah. Second, I would like to quick. Yeah. Two panelists have suggested private sector as the solution. So I would like to see how you see as a more developed private sector as a solution for strengthening public sector. In fact, it is the other way around. The poor public sector has given way. In fact, the governments have facilitated the developing of the private sector, and which is leading to commercialization and to increased out-of-pocket expenditure of masses.
The national health policy sets this principle quite clearly.
No, but that needs to be investigated.
No, just hear me out.
We cannot take it.
What we have said is we need social protection schemes that give people the opportunity to access care. Whether it is public sector or private sector, both need standards, evidence-based protocols, they need quality, they need good services, and the bad ones in the private and public sector should all be punished by an accountability system. Now, when he said that please use private sector by engaging with them, TB control is a beautiful example. all analysis in the country, in China and South Africa, have shown that public sector treatment of TB is much better than the private sector. The time to starting treatment after the first appearance of the patient is better. So what did we do in the next TB program? We engage with the private sector and say, here is a place where you can do better. So remember, these are all Indians, the public and the private. And every system needs a strong public system. There's no question. But that does not mean that we should not enable people to use private sector, wherever private sector can make a strong contribution. Both are needed, but we need a social protection system, and in the next session that will be discussed. Come on.
Sir.
Yeah.
Sir, I am Dr. R.B. Singh, retired from State Services last year as Additional Director of Medical Health. And now I am in the private sector and working in a private medical college as medical superintendent. Sir, first of all, I have been enlightened by the representation of the experts. And ultimately, I was very much impressed by the presentation of Dr. Jani, who has started working from PSC level and he has reached to strategic level. So I consider that he is in the best position in helping in drafting the Uttar Pradesh health policy or policy of any state. The second comment is that the two ends don't meet. Dr. Awasthi is sitting here. She represents the medical education department. She is the producer of human resource and we are the consumers. When the medical officers or other healthcare workers, they come, they are functionaries in the department. But I don't think that in any state, especially in Uttar Pradesh, there is no coordination between medical education department and medical health department. That has to be addressed at top level, at ministry level, sir. Number 3, sir, you are here to discuss public health in UP challenges and solutions to draft the Uttar Pradesh health policy. To my surprise and to my utter depression, there is nobody from the medical health department, including our DG, and whole of the department is sitting here, all the officers, right from the joint director to director general. There is nobody to take part in the discourse and the discussion, and that is sad part of it.
Good point. Next.
I'm Piyush from UNICEF. I just want to bring only one point as part of the solution. When connecting 2-3 dots across the panelists, there's a discussion about 14th Finance Commission, devolution of finance, UP being a big state, and governance and community awareness. I think one beautiful opportunity is the GPDP with the Gram Panchayat Development Plan, where there is a provision of low cost and no cost activity can be included at the Gram Panchayat level. And I think whatever we are designing, I think we need to engage Panchayat in a much more serious manner. We need to get out of all the prejudices we have against Panchayat. We should trust the Panchayat and the people, and we should engage any discussion, anything that we are designing regarding health with GPDP.
Very good point. I think you will hear this in the health system discussions. Primary health care has to be transformed. He made a beautiful point. Without the ANM, multi-purpose worker, ASHA, the community forces, you can't have a health check. How do we optimize and transform that instrument with micromanagement strategies, district-based strategies, and this managerial brilliance combined with that skilled workforce? Because the amount of work, in fact, you have to remember, treatment of chronic diseases in OECD countries, 80% is done by primary care people. So for future, it's not only maternal child. The whole chronic disease program, the pillar of it will be the primary care system. Who's screening people today? Who's checking blood sugar and blood pressure? These are primary care workers. So there is no question in my mind that your biggest challenge is what is the design of the future primary care system. On that foundation alone, you can build tertiary and secondary level system. So that's well put, and I think that's one thing we must transform. Who's coming next? I want some interesting ideas, some new strategies.
Yeah, I'm Dr. Puri.
I'm not hearing enough creative ideas.
What is that very simple observation? I hope it is not taken otherwise. We are discussing maternal mortality, and on the panel, we do not have a gynecologist who is looking after the mother prior to the conception, during the conception, during the probably that would have added in whichever way. And the
I
second
will
point,
accept that point, except that you must remember one thing. The 4 people
all the
who
people
sit
are
here
perinatal medicine
are
specialists.
as engaged with the concerns of pregnancy and adolescence
Definitely.
as gynecology.
Definitely, but we are talking about maternal mortality.
No compartment.
And
this
no
is public
compartments
health.
as such, but I am sure
Okay,
if you
fair.
realize
Good
that
point.
clinically there is a requirement where
Fair.
gynecologists can add reduction in maternal mortality.
Fair enough.
This is one point. Second point is, I will take it up from Dr. Sunil, which he said that the men and the boys, they should be, enhance their education or that thing. But a word which I want to add for that is empower, where the M is the male as well as it's a capital word. So if that can be taken up on a larger platform in the community, probably we will have a lot of changes happening in the social structure as well as the spending of the family, as well as the taking the decision where to show, what to do, whether should we do this or not, utilize this particular facility. So these are the points which I
Thank you very much. I think one point I would like to emphasize here, you have an opportunity with the second AIIMS, and please make sure that you design the second AIIMS role with greater clinical abilities and not duplicate the role of the first AIIMS. You will not get enough return. Because this whole idea of village health and wellness centers is that some people should be sitting there the whole day and not mobile while others are doing other things. So there is a good design opportunity for you about how to design both the village health wellness centers but also the role of the second AIIMS. And that I think you should carefully consider. Yeah.
Good afternoon, Dr. Manjusha, I'm a gynecologist. 70 years into independence and we are still struggling with programs and so many policies, and still we are way behind the expected or the target MMR. If we look at the grassroots level, I did a study on MMR on a Delhi hospital and we studied more than 1 lakh deliveries, and what we realized was that more than 50% of the maternal deaths are due to anemia. We are born poor. The women in our country suffer from mental power.
Do you have an idea for faster control of anemia?
We need to educate school girls, nip them in the bud. We talk to them in the school. We tell them to demand from their parents as to give them the food which they give to their brothers. The girls are poorly fed right from day one. They have to starve, they have to fight for their rights, they have to learn to fight for their rights. We have to have strong girl child, to have stronger women.
Let me share with you a new idea on control of anemia that we discussed.
Yes.
Our whole strategy for control of anemia is prevention with a higher than preventive dose, right? Twice weekly. The point that is being argued is, if we are screening the population for hypertension and blood pressure, why are we not screening the population for anemia and actually treating anemic people with proper doses of iron and folic acid? So if some of you should take up pilot projects and examine this process, right? So this anemia control strategy is a failure. Try new strategy. So that's our message. Yes, I agree with you. And as I've told you, anemia is a disease. Anemia cannot be treated with twice weekly 100 mg. And I don't know what harm that large dose does to the gut. We should try a screen and treat approach for anemia. That is the idea being discussed. So if we are prepared to do a couple of pilot projects, we can find the way to participate. So let's experiment and learn. Any other thoughts? Anything that you want clarification from the panel members on some strategies they've suggested or some goalposts? Somebody has something to say that might inspire all of us? We want to end this discussion.
Dr.
Yes.
Shally Awasthi's response upon my question.
You had multiple observations. Last, no response needed, DGHS not here. So you also said...
no, not DGHS. Role of medical education in
yes.
harnessing.
No, now,
harnessing the human resource.
when you talk about medical aid, you are talking about medical institutions and medical colleges.
Yes.
And you are talking about in-service capacity building of those people. Now, this is too much for a medical institution to take up. And for in-service capacity building, other services have staff colleges and other things. You will need a proper strategy for in-service capacity building. We can chip in, but I don't think we'll be able to take the role at all because our primary responsibility.
I can help you with this. There are 5 or 6 human resource challenges we have. A, both the clinical and managerial skills of MBBS doctors, whether in medical college or in situ in training. 2, ability of ANMs, nurses, to assess clinical patients for mild versus severe illness. They've just not been in that track. We have trained ANMs in IMNCI. When I ask them questions, they still look confused. So how do we build the clinical component of a nurse's skills or an ANM skills is the second challenge, because this whole edifice of village health centers, these new centers, is based on these workers. Third issues, and this I have experienced this even when I was running the Ministry of Science. Training has no scale in this country, and nobody even visits those training schools for quality. Who has ever evaluated an A&M training school? When? So I think we need a more comprehensive strategy for how to train huge numbers of people. Does Shally have a budget for running a training program? How is she? You've been to a medical college, you've all been there. They are running outpatients, running rounds, they have postgraduate students, they have ward rounds. They need training centers and training grants where they have additional staff that is used for training. No government in this country funds training centers. So I think UP should carefully. So remember, ultimately it is all common sense. अब मेरे से 1.5 लाख काम कराओगे तो मैं नहीं करूँगा, मेरे से नहीं होगा,
Sir.
है ना? तो empower me, give me a training center, I will train you 500 people, right? That's what she's saying.
No, sir, you have not included my point. My point is that how to compensate the deficiency of existing human resource. Not that means not only doctors, that includes nurses and pharmacists. आपने बताया कि यूपी में somebody told the data. It's 40% of 50% of doctors posts are vacant, 30% nurses are vacant, and there are no paramedical posting. आप यूपी की ड्रॉप पॉलिसी में लिख लीजिएगा कि इतने प्राइवेट कॉलेजेस को, नर्सिंग कॉलेजेस को, पैरामेडिकल कॉलेजेस को उत्तर प्रदेश सरकार ने मान्यता दे दी है. वो बेरोजगार घूम रहे हैं, हमारे पास ट्रेन मैन पावर है और दे आर नॉट बीइंग एम्प्लॉयड. फार्मासिस्ट के लिए डिपार्टमेंट कोर्ट में टहला रहा है फार्मासिस्ट को.
You have made an excellent point.
Yes.
The point here is this:
human resources available, that is not being employed.
So I think one suggestion we can conclude with, that we need a small group to really examine the human resource issues very systematically while this policy is being drafted. I would actually say this is a top priority, because without looking at facts, looking at is it an input problem, is it a skill problem, is it a job creation problem, is it a job filling problem? Are people dissatisfied? Is there salary issue? And there are some states where MBBS doctors get 25,000 rupees salary for 2 years. Punjab, Himachal Pradesh, can you believe this? 25,000 rupees after the medical degree. Now, how the hell do you expect somebody to work in public service? But these must be documented carefully so that our political leadership understands where the problem is. So that's what we are suggesting, that while this policy is made, examine HR issues in detail through a group that is competent in process to be able to give us advice. This is an important problem. Do any one of you want to say something?
For inclusion into the minutes or the suggestions, I would say certainly maybe the new leadership at the bureaucratic level and of course political level is being built here and they're looking into solutions. One good thing would be to visit a state like Tamil Nadu with a practical solution, because many of the things that we are trying to grasp and grapple with, there could be some innovative solutions or solutions that you can adapt. So that can be a wonderful, thing to do at this point in time. Second, sir, I have a issue that if you're looking at developing a policy document, generally that stays very high out here. And some components are not fully developed and you can take your own sweet time, NCD, maternal health, aging. But for things like RMNCHA, MNCH, maternal child survival and thrive, the nutrition part, this cannot wait for policy to then go downstream to become strategy and action plan. So I would say, right away start working on those goals and develop an MNCH action plan 2017-2022 right away. Don't wait for it. Because we already know what needs to be done. What you must ensure in that action plan is of course timelines and what needs to be done, but also how you will run it as a mission. The governance structure and commitment to the bureaucracy and the political leadership must be there and monitored systematically. So please don't get stuck with the policy before you go into action for LNCS, because that's our unfinished.
I'm coming serially from here, so each one of them may come.
Just a point. You already have, as I think Dr. Paul was saying, a lot of people talked about the community and ownerships. Let's get VHC functionally each village. Just do that and you will get many, many fold advantages of micro-planning, participation, and many other aspects. Point number one. Point number two, I think being part of the policy process, I've been part of the 2-3 meetings that have happened in the state. There is a lot of emphasis on HR, please. And I think there's a lot of solution being talked about, which are multifold. They are not just one. I think there are 7-8 different ways that HR is being considered and you need to see which district wants to adapt which kind of a pattern to get its HR addressed and give this ownership to the district to, out of the box of these 7-8 solutions, pick up one of them, right? Even taking the retired personnel like you back into service for some year after doing some screening. I'm just giving it as an example. So there are many ways that they're looking at getting the HR addressed. Third and last, I think the biggest challenge is the absorption capacity of the state. I think this is the huge challenge that the state has. And this has to do with the governance and the multiple departments that exist and the conflict in these departments in terms of their role and distribution. So at the larger level, the governance also need to be reviewed from the point that you said about medical education and the human resource. I think these departments need to come together for their commonality of agendas rather than playing multiplicity of role. I produce MBBS, I make public healthcare professionals, I make paramedicals. That's not going to work. You need to have a continuum in the state where there are institutes of expertise providing not just medical educational aspect, but like A&M training centers, and the excellence of those centers need to be understood and they need to be rolled out. I think policy will look into these processes as you have suggested, and I think the point that is being said is well taken in different aspects of its solutions.